Got Paul Seegert joining us, managing partner at PCS Advisors. They're a health benefits consulting firm. A lot of folks interested to know what the future of Medicaid is, and we've got Paul here to talk about it. Paul, welcome to the program.
Thank you for having me back.
Well, tell us, where are we at when it comes to Medicaid?
Well, we have a bunch of people that are currently on Medicaid rolls who don't qualify necessarily by income and the other requirements that you have to meet. And part of our whole COVID experience was that we gave extra funding to states to allow for that to occur so long as they didn't audit the enrollment after people enrolled. So they had to be able to qualify initially, and then they didn't audit it in an ongoing way like they would normally do. And as soon as the emergency ends, then that extra funding will cease. And then you can be sure states, and different states might do it with different rates of speed, but they're all going to end up beginning to audit those rolls again. And that will have a big impact on the overall Medicaid enrollment. Medicaid is one of the biggest line items for lots of states. And depending whose numbers you believe, we could have anywhere between 8 and 14 million people on Medicaid that may not qualify after these rolls get audited.
And what's the process of that?
Well, they have to reach out to each of these people, which, when I just said millions of people, this starts to sound like a pretty big mess. They're going to have to reach out to each of those folks that are enrolled and then verify their eligibility. So we're really in pretty uncharted territory. We've never had this kind of thing occur where you have this many people added to a program that then sunsets and you have to go back through and audit it all. And it's going to be quite a project.
Yeah, I bet so. Now, what should folks be as they're listening and it's like, oh man, there's some concern. What should they be watching or researching or looking to do?
Yeah, many of these people will have coverage available at work. I think that's the first place to check because of the fact that your employer likely covers a very significant amount of the premium if you go there. And if you have it available to you at work and they cover a significant amount of the premium, then you may not qualify for subsidies on the exchange. So step one, check with your employer. And then step two is go to the exchange and see what the plans are that are available there. And many people that don't have that coverage available at work or it's not deemed affordable at work while they may be removed from Medicaid, they'll still qualify in many cases for a significant subsidy through the exchanges.
Yeah, wow. That's really important information. Now, obviously, if you don't have employment, you're retired, what does that look like?
Yeah, those folks will be transitioning to Medicare. Likely they're already on it. But if you have folks that are kind of right at that age where they're moving that direction, then they'll end up with a special enrollment period to join Medicare. And you'd want to get someone that's an expert in that to kind of help you with that process.
Okay. All right. What else should folks know, Paul?
Well, I think we've hit the big high points. Don't wait till the last minute. It's a confusing health insurance is unfortunately confusing. You'll have a 60-day special enrollment period if you are removed from a program. So don't wait until the last minute. Get ahead of it. Do some research for someone that can help you in your area. There are lots of folks out there that can do that.
Yeah. And what's happening overall in just the healthcare industry as a whole? I mean, the U.S., I think the last couple of years has just kind of shown in some ways, just the weaknesses of where we're at. What does the future hold for healthcare industry?
I do have some optimism, believe it or not. There's weaknesses all over because of just aging demographics and other factors. So all over the world, you look at the UK right now and their program, their National Health Service, many employers are starting to offer private insurance because of the long waits to get care through the National Health Service and so on. So it has its own challenges. Here, our biggest challenge is that we haven't had the political will to create transparency where a free market can actually perform. And we're starting to see employers that have plans of some decent size making demands around that transparency and getting better results. So to me, that's kind of leads the charge of optimism. And then you're also seeing, I think, enough frustration with just American consumers broadly that you even have 2 out of the 3 big insulin manufacturers that just come out in the last 30 days and said they're going to voluntarily lower the cost of insulin 70%. That's incredible. And, it's not that they're, magically became altruistic. I think they see that there's enough momentum and pressure and that it really is getting to a breaking point. We can't ask Americans to spend, this economy shouldn't have to spend 30% of our GDP on healthcare, and that's where we're heading if we don't do something. And there's enough frustration, I think, that we're at an inflection point where even politicians, even knowing that we have 14 or 15 lobbyists per member of Congress to keep it the way it is, I think the pressure is building to a point where we might actually get something done.
What would you say are the 2 or 3 things that if you're calling the shots, this is what we need to do?
Yeah, we need to be able to, we have to create a payment model where the American consumer has the information they need to consume well, like they do in all other areas. It's crazy that I can use this powerful smartphone that I'm using to talk to you right now, and I can find out what a big screen TV costs all around the world and close to me and online, and I can shop and consume effectively. And I can't do that with healthcare. And the fact that it's a complicated product to consume is no excuse. So we need to create transparency rules where, and there's proof that these free market forces can't work. Look at procedures like elective procedures that people get all the time, and where the insurance payment model is not involved, whether it's cosmetic or otherwise. The quality goes up and the cost goes down consistently. We need to make that possible in the overall consumption of healthcare. That just whatever those rules are, and they're transparency rules primarily, so that hospitals have to compete for your business, surgery centers have to compete for your business. And then we need to bring serious transparency to the way we consume pharmaceutical drugs in this country. The fact that we are 80% of global profits for Big Pharma. Yeah, we take more drugs here in other countries, but that's still way out of whack. And it's because we don't require transparency. There's no way that a plan sponsor that's running a health plan shouldn't know what the drug actually cost versus what they had to pay for it and where all the money went. It's a wild lack of transparency that we deal with in the current system.
So the U.S. consumes 80% of pharmaceuticals worldwide?
No, but we provide 80% of profits to Big Pharma. So we consume far less than 80%, but we pay, for many drugs, we pay 10x what our peer countries pay for the very same drug out of the very same factory. Those countries won't. They'll simply say, if you want to sell your drug here, you can't sell it. You can't come in here and sell it for $10,000, but if you want to sell it here for $2,000, go ahead. And so they do. And I'm not advocating for price control, but I am advocating for some reform in that area. I mean, it's the free market. We need some guardrails put up that are sensible, that protect the consumer, that we don't have today.
Yeah, I mean, I think there's a lot of folks who don't even want to know how the sausage is made when it comes to this.
It's quite a rabbit hole.
I mean, what are? Tell me, what are a couple of the most egregious kind of norms in that the average person just doesn't know when it comes to the healthcare industry?
Well, a typical hospital has more than 150 prices for every procedure they perform, and a tenfold difference in what you might pay depending on what health plan you have. That's crazy. Why is it? I looked at
break that down.
A minor heart procedure. Yeah, I'll give you a real example. I looked at a minor heart procedure for a client company in Central California. Depending on your health plan, same surgeon, same hospital, same procedure, your plan would pay anywhere between $80,000 and $540,000. Same procedure, same surgeon, same room, same everything. That's ridiculous. And that happens because we don't have that information as a consumer. We just have, hey, this is my copay, this is my coinsurance, this is my deductible, this is my max out of pocket. And they don't really have any relation to real cost. You shouldn't have what does it cost to perform the procedure? What's that cost plus reasonable profit? Go out in the free market and compete for clients with that. That doesn't happen today.
Yeah. And who pays the price?
Well, we all do in our premiums. We all do in our premiums. And it's the other thing that a lot of people don't realize that is shocking is the fact that the private payers in this country, those of us that get our coverage at work, are now 49% of covered people in this country. 20 years ago, it was 2 out of 3 of us. And that funds the profitability of the whole system. It props the whole system up. If you show up at a hospital today and you have Medicare or Medicaid, they're going to lose money, most likely, on your care. And they might need 120 to 140% of what they collect. That our system overall functions because when that person shows up with an employer plan, they're going to charge them, according to RAND, who just did a study of 4,000 out of the 6,000 hospitals in this country, they're going to charge that plan 224% of what they charge Medicare and Medicaid. I've seen it way more spread than that. But even if it were just that 224%, that's a significant difference. And so a lot of folks will advocate that a solution might be a single payer. Let's do what Canada's doing, the UK's doing, et cetera. It won't look anything like what you see today. They lose money on the math that you're doing. If you're going to take Medicaid math and extrapolate it out across the whole population, that wouldn't work. They're losing money on those clients today. And it doesn't mean we can't make it work. I believe we can. The thing we're good at here is as a free market. Ironically, we haven't put the guardrails in place for it to occur when it comes to consuming healthcare.
Yeah, I got a few more questions about this. We're talking to Paul Seegert, managing partner at PCS Advisors. They're a health benefits consulting firm. We'll take a quick break. We'll be right back with Paul after this on Live from Seattle. Welcome back to Live from Seattle. Thanks for being with us, and especially on this gorgeous day. We're so glad you're tuning in. Talking to Paul Seegert, managing partner at PCS Advisors, a health benefits consulting firm. And Paul, we're talking about the U.S. healthcare industry, and one of the things that, you know, when you juxtapose what we do with Canada or Europe, certainly there's probably pros and cons in multiple angles. And the part that is interesting, and you mentioned the free market and how, like, in the healthcare industry, it's a free market, and there's some good things about that, but in a lot of ways, we know that greed is greed can rule the day, right?
Sure can.
We've seen this play itself out time and time again. How when money is involved, it is the source of all evil, right? And when you throw people's lives into that, right? When you throw healthcare into that, and you mix greed and money and then people's health, that can be a really toxic combination. And what are ways that we can somehow mitigate just the incredible greed and money that influences people's life and death situations?
Yeah, that's a great question, and I agree. And I'll give you a quick example that kind of hammers that point home, and that is the fact that we have a shortage of pediatric hospital beds right now in this country is manufactured. It's created by what you're describing. When a large percentage of the kids in this country are on Medicaid, and facilities lose money on those parts of their hospital or on those procedures, they simply quietly reduce the number of pediatric beds and make more available for things like knee replacements that are profitable and other adult care and elective procedures and so on, because that drives revenue. And I think if we can bring incentives for them to do the thing we want them to do, they'll do it. But you can't ask these for-profit institutions to lose money and continue to do something. They're just not going to do it. And actually, not-for-profits won't either. We've got an unfortunate trend where not-for-profits are closing facilities in poorer areas and opening a new facility in a richer area because they know that the payer mix will be better. They'll have more commercial payers. They'll have more people with their health insurance there, even though they're getting tax breaks and other subsidies from the government to provide charity care. It's because that government payer, the Medicare, Medicaid, now represent half of people walking in the door in just the general population, and they can't survive on those reimbursements. So I think we have to, the government, if you're going to be on a Medicaid program, I don't think it's certainly worth a conversation as to whether that program should pay enough for the facility to be profitable on that. And if we can step up and do that, then they'll continue to offer those services more broadly. We can't have a situation where we put more and more people onto programs that don't compensate providers enough to cover the cost of service. It just doesn't. The math doesn't work.
I mean, you talk about profits, but aren't some of these hospital execs and aren't they just making hand over fist money? We see that not only in places in just regular kind of the business world, right? Where you'll see Amazon, they just announced they're laying off 1,000 people, right? But their executives are making just obscene amounts of money while at the same time they're laying people off. Like, should there be it is a free market, right? And if someone wants to make $100 million a year, then I guess that's, then they can, right? But at the expense of people who are getting laid off, isn't there some kind of especially that's business, right? When it comes to healthcare, isn't there some kind of regulatory things that really looks out for, the consumer?
There should be. And I'm going to agree with you on this. We've done a bad job in this area. You see them, the government stepping in and being the referee and saying, hey, we're not going to let two discount airlines merge because we think it would be bad for pricing for the consumer. Yet we have allowed monopolization of healthcare to occur. You have a huge percentage of our country where it's highly controlled by one health system, what's available. And they have allowed that consolidation to occur because it would lead to efficiency that could get passed on to the consumer, but it consistently hasn't been passed on to the consumer. Prices have been shown to rise. When we allow monopolies to form, prices rise. That's not free market. That's allowing monopolies. I know we're a free market country in theory, but we've really not. And same thing, we've allowed health insurers and pharmacy benefit managers to consolidate. And that's removed some checks and balances in the system. And drug prices have grown tremendously. We've allowed some very concerning consolidation and vertical integration to occur in the way that we all pay for health care that has driven up costs tremendously for the consumer.
Yeah, here in the Northwest, we've had some big mergers take place. Here in Virginia Mason, CHI Franciscan with Swedish. There's just been a consolidation that's taking place. That's not going to help things moving forward.
No, it doesn't. It's been shown to be negative, yet it continues to be. They continue to get the blessing to do it, and it continues to drive up cost. You can come back 12 months later after one of these mergers, and you see costs go up 7, 8, 9%. Some markets, 18%. It's incredible. And you kind of don't see it as a consumer because you're just paying your monthly premium, or it's payroll deducted through your employer, You pay your copay. It's a little bit invisible. It's kind of back behind the curtain, but it shows up in your next year's renewal increase in terms of your premium increase.
Mm-hmm. Yeah. I mean, what are some things you've seen, let's say from Canada or the UK, where you would say, hey, we need to maybe mimic that or look at what they're doing?
Mm-hmm. Yeah, a lot of it I'm not in favor of, but there are some things that I am in favor of. An example would be the fact that we have 3 insulin companies that have pretty much run the roost for 100 years on insulin and don't have any real access to alternatives is because we allow things in our patent laws that other peer countries don't. We allow them, if a drug, you get a certain period of exclusivity. Well, we want that to allow a drug company, to encourage them to invest in creating a treatment and being able to get the return on that. But we have to balance that with what's reasonable for the consumer, and it gets back to that greed word that you brought up a minute ago. In our country, you can get toward the end of that period of exclusivity, modify the drug a little bit, and kind of hit the reset button on that period of exclusivity. So you'll have a Humira, was the most commonly prescribed specialty drug for a long time. Finally, we're getting some biosimilars in this country. Well, it's been around since the 70s, I think. And long since would have gone past its initial period of exclusivity, but you keep adjusting it. And it can't be purely coincidence that a lot of these adjustments and improvements come out right as the exclusivity period is sunsetting. So we allow things like that are really not free market. We're not protecting the consumer. The lobbyists are winning there. We're protecting the industry at the significant expense of the consumer, and we shouldn't.
We've been talking to Paul Seegert, managing partner at PCS Advisors. They're a health benefits consulting firm. Paul, we appreciate you taking the time today.
Thanks for having me. I look forward to speaking with you soon.
Excellent. Thank you so much.